Hi, everyone. My name is Dr. Daniel Guss. I'm one of the orthopedic foot and ankle surgeons at the Massachusetts General Hospital. So thanks so much for the opportunity to be involved in this amazing initiative. One of the things we love about academic medicine is the opportunity to build bridges. And so I hope that this is the beginning of a conversation rather than an isolated presentation. And so today I'm going to talk about ankle fractures. And it was critically important for me that this be helpful. And so I found that case presentations are sometimes the most helpful because it's going to bring up what you face in real life. These are my disclosures. None are related to this talk. And so historically, I've given a talk like this to the residents where it's interactive. We're gonna, obviously this is a non-synchronous Zoom presentation. But I do want to take pauses and try to make this as interactive as you can with an asynchronous presentation. And what specifically I want to talk about is starting from the ground up with ankle fractures. What are our surgical goals? How do we think about fixation strategies? And as with anything in life, what is the role of compromise? And so I start with this slide, and I think this is going to be probably the singularly most important slide in the presentation, which is a little bit counterintuitive because this is a picture of an ankle that actually is not fractured. And the reason I bring this up is because when it comes to orthopedic surgery, and this doesn't matter what part of the body you're talking about, everything, your success and your ability to help a patient is predicated on your knowledge of anatomy. And if you don't know the anatomy, then you're going to be unable to safely help the patient. Whereas if you do know the anatomy, even if it's a procedure you're less familiar with, you will almost certainly figure your way out. And so this is a cross section of an MRI. And when we talk about the ankle and how to fix fractures, we talk about windows. You have to be able to access the fracture. And so these are the various windows. One of the first things you do when you look at an ankle fracture is think about, what are the structures involved and how am I going to approach it? What window am I going to use? And when we talk about windows in orthopedic surgery, we actually often talk about what are called internervous planes. An internervous plane is basically an approach to an anatomic structure that splits muscles that are innervated by different nerves. The idea behind that is that you're going between muscles that are different nerves so that you're not denervating a muscle, meaning the muscle is not losing its blood supply. If you go down right through the middle of a muscle, then whatever is in the direction where the nerve is coming from is still going to work, but whatever is downstream no longer has a nerve supply, and that part of the muscle is going to fibrose and die. And so these are the approaches that we use in the ankle. This is and I'll go clockwise. This is the anterior medial approach if I need to get to the anterior medial aspect of the ankle. And so the anatomy that you're working around, this black structure right here, is the tibialis anterior tendon. You're actually working around it. And the reason that's an internervous plane is that the front compartment of the leg is innervated by the deep peroneal nerve, whereas the posterior one is innervated by the tibial nerve. I purposefully draw this arrow a little bit curved, because if you're going to do a direct approach to the tibia here, that's a portion of the tibia that's right under the skin. It's subcutaneous. And so by curving it a little, you offset your skin incision a little bit from your fascial incision, minimizing your risk of a wound complication. In turn, the direct anterior approach is not an internervous approach, but you're far enough down that you're not actually at the muscle level. You're at the tendinous level at the ankle. So here what you're doing is you're splitting the tibialis anterior with the EHL, the extensor to the big toe. Here is the neurovascular bundle that you can see right underneath it, and that's the anterior approach. This is the approach we often use for things like total ankles. The anterior lateral approach then is an internervous approach, whereas you're splitting the anterior compartment, innervated by the deep peroneal nerve, and the lateral compartment, which is the superficial peroneal nerve. And what you actually do when you do this approach is you go equidistant, you split the distance between the front of the tibia and the fibula, and you elevate the entire anterior compartment. You are going lateral to the extensor digitorum longus. The direct lateral approach is what we very routinely use for ankle fractures at the subcutaneous portion of the fibula. Again, this is an internervous approach, similar to the anterior lateral. The posterior lateral approach is used when we are trying to fix posterior malleolar fractures, at least with some frequency. And then again, this is an internervous approach. These muscles right here are the peroneal muscles. They're innervated by the superficial peroneal nerve. And behind it is the Achilles. We're splitting them. So you're splitting a muscle group that's innervated by the superficial peroneal nerve with one that's innervated by the tibial nerve. Once you get deep, this muscle right here is the flexor to the hallux, the FHL. And then you elevate that off the back of the tibia. One of the things they love to mention on tests is that this is the muscle that extends furthest down the ankle, in the back of the ankle, meaning its muscle belly extends well beyond that of the flexor digitorum longus here and the posterior tibial tendon. And then lastly is the posterior medial approach. This also allows us access to the back of the ankle as well as somewhat medially. The advantage of this one is that if you ever look at a sawbones of an ankle, when you do a posterior lateral approach, you can fix the posterior malleolus, but because there's an overhang of the posterior malleolus, you cannot see the articular surface. When you're reducing the fracture fragment, you're doing it based on the triangle that is at the tip of the posterior malleolar fracture, as well as with the use of fluoroscopy. Here, because of the shape of the posterior tibia, you can actually see into the joint and work on articular fragments. You do have to work around the neurovascular bundle and dissect it out. This is not a true internervous plane in the sense that all these muscles involved are innervated by the tibial nerve, but they're innervated well proximal within the leg, and so you don't denervate them. And so this is, again, the singular most important slide on this presentation, because if you understand the anatomy, there's little in the ankle that you can't at least get to and try to fix. And so then I want to start with cases. This is a 28-year-old male who had recently undergone fixation of a Lisfranc injury. He was actually starting to do really well, but as you can see, he was perhaps a little bit osteopenic after a period of non-weight bearing. And shortly after initiation of weight bearing out of the boot, he twisted his ankle walking his dog. And he comes in with these films. This is the part where in a live presentation, I would ask someone to weigh in and read these films. But what you can see, and it's harder because of his bone quality, having been non-weight bearing with the Lisfranc, is that he has a fracture of the lateral malleolus. Here you can start seeing an irregularity at the medial malleolus. And then you can start seeing a fracture of the posterior malleolus. Notice that on these views, the ankle itself does not, meaning the tibio-talar joint, does not seem subluxed or dislocated. And so when patients come in with a trimalleolar fracture, I have a very low threshold, and if it's readily available, I realize this may not always be the case, I have a low threshold for ordering a CT scan, just to better understand the posterior malleolar component as well as other aspects of the fracture. And so in his case, that's what we did. And as you can see, it confirms what we saw in X-ray. He's got a lateral malleolar fracture, a medial malleolar fracture, and a posterior malleolar fracture. Now, in a live presentation, what I often ask the residents is, what would you do? And the reality for the majority of people, and there's a reason I start with this case as number one, is if you were to tell me as an orthopedic surgeon, let's say you're covering the ER and you call me on the phone and said, yes, I've got a young individual with a trimalleolar fracture in the ER. The reality for me is I'll default into thinking this person needs surgery. And the majority of the time, I would be right. The interesting part about this patient is if you notice, the tibio-talar joint is very congruent. So never lose sight about the number one reason that we fix ankle fractures, and that is not because of the fracture. It's because the fracture has rendered the tibio-talar joint incongruent, meaning the talus is starting to move from under the tibia. And the talus, the ankle joint, is very resistant to arthritis, except in the setting of trauma. The majority of ankle arthritis is post-traumatic. So even 1 millimeter shifts of the talus relative to the tibia can precipitate this. And so in this case, given that he had such congruency, I asked myself, what would I be trying to make better with surgery? What am I realigning? And the answer for him is he was pretty aligned. And so we treated him non-operatively, and he actually did really well and went back to athletic endeavors. And so I start with this on purpose. Remember why we set out to fix ankle fractures to begin with. This is the case of a 21-year-old female. She had a BMI of 57.8 and slipped on ice. And so as you start looking at the fracture pattern, you realize she's got a comminuted fibula. She's got a small avulsion crease at the medial malleolus. And notice that without doubt, she's got syndesmotic instability. The fibula is much too wide, much too distanced from the tibia. And so this is always what I want you to ask. What are you going to fix, and what construct are you going to use? And what I mean by that is, remember that her fibula was pretty comminuted. And so when you think about goals, we often fix the fibula first, not invariably so, but often, is we need to get fibular length. In her case, I knew ahead of time that she was very comminuted at the fibula. And so I needed a way to get length that would not involve getting the puzzle pieces to fit perfectly together, nor did I necessarily want to start dissecting out every little comminuted piece, because then I'm creating a devascularized segment of bone. And so the strategies you can use to get fibular length, including getting a tenaculum at the tip of the fibula. And so when I'm reducing a fibular fracture, I'll always have two tenaculums, one pulling length, the other trying to reduce even without comminution. Other things include Hintermann distractors. Those are little distractors that you put wires and then you push the wires apart. In a fibula, I always put them at the front of the fibula so that I don't fight my plate. You can also pull it out to length and then use the plate itself and lobster claws. In this case, this is a trick I like to use, which is pull it out to length and then actually fire a K-wire from the tip of the fibula into the tibia to hold it out to length so that this doesn't fight my plate. And then there's the classic AO push-pull technique where you fix the plate distally and then you put a screw proximally to it and use a clamp to spread and push the fibula distal. That can be a little bit tough because even 1 degree off of rotation in the fixation distally means in a very proximal fracture that your plate may be off the fibula. But the key is don't forget the vascularity. Don't forget that bone is a living part of the body. And so notice here, we didn't dissect out those fragments at all. I knew ahead of time that I would be doing a bridge plating technique. And so then you can put your plate on, pin it together. These are olive wires. And then fix your plate as well as the medial malleolus. And then put a tenaculum. And then syndesmotic screws. And so in this case, you know ahead of time what your goals are and build around that. You don't want to figure out that you're going to use bridge plating once you're in there and realizing that those two fragments are too small to fix. Here's a small note on the use of a periarticular reduction forceps, those clamps that we use to fix the syndesmosis. You do not want to place the lateral tine proximal to the incisura. I'm going to go back. You do not want this tine to be above this region. The reason is because if you put the clamp up here where there's empty space between the fibula and the tibia, this gives you enormous leverage. It will bend, it will push the fibula and then potentially cause it to bend at its weak point, the fracture. Here, because you're pushing the fibula into its articulation at the incisura, that doesn't happen. And then when you medially, if you have a vertical shear fracture medially, make sure that the medial tine is proximal to the fracture. If you put that tine at the level of a vertical shear, it will displace the fracture. And so realize that the periarticular reduction forceps is a very powerful tool, but with that power comes the mechanical ability to displace your previously fixed work. Here's a note on the medial malleolus. Whenever I'm fixing a medial malleolar fracture, I always elevate the soft tissues anteriorly and perform an arthrotomy. I will look through the fracture to make sure that the patient doesn't have an osteochondral defect. If they do, you can treat it at the time. But you can also see the anterior medial joint line. That helps you with your reduction. I always look at what I call the shoulder. And you don't automatically have to use 4/0 screws. In this patient's case before, her fracture fragment was so small that we used solid 2.7 millimeter screws, as well as washers. I have a very low threshold for washers. And this is how she was at follow-up. And this is the note on the periarticular reduction forcep. This was a patient that had a high Weber C. I had actually gotten to get it perfect with a 2.0 millimeter lag screw and then put the plate on. But thinking that I want to use the distal hole in order to place my clamp, I put in order to put my first screw, I put the clamp here. And as you can see, it very slightly displaced my fracture fragment. And what happens? This is a very rigid construct. And so it's going to heal not with relative stability like a bridge plate, but with absolute stability. If you go back to your basic anatomy, those are the basic microbiology or biology, it's cutting cones. There needs to be bone-to-bone contact. Osteoblasts can't jump. And so what happened for her is this is at 2 months, this is at 4 months, and this is at 6 months. It healed, but it took a long time. This is a 70-year-old male who slipped on ice. Again, as you can see, this is a more oblique-oriented fracture fragment in addition to the fibular fracture laterally. And when you get the CT scan, you see that he has a fracture line that extends very anterior medially. And so this goes back to what we talked about before with windows. What windows do you want to use in order to fix this ankle fracture? Now, you could go medially directly, but then you're going to be very dependent just on this fragment fitting up here. Or you can go anterior medially, which helps with 2 reasons. It lets you see into the fracture, but it also then lets you put a medial plate without that plate being right under your incision. And so that's what we did. And as you can see, this plate offers a buttress approach. As you get to vertical shear, that's when I start using more of a buttress plate, because the screws are very good at compression, but they are not good at shear. And so when you fix it, you put the screw above the fracture first, and then I will actually lag the inferior screw in order to compress that downwards. So this starts making us think about both the windows we talked about, as well as the fracture fragment orientation. This is an example of an 80-year-old female who slipped on stairs. As you can see, she's got a fracture of the fibula, but also a sizable fracture fragment at the distal tibial plafon. So this is starting to verge away from ankle fractures into more to the pilon realm. We used a temporary external fixation. She was very swollen when she first came in. And as you can see, there's a big step off in the posterior joint line. So she needs something done in order to realign her plafond. And then we got a CT scan. The traditional teaching is to get the CT scan after you put on the external fixator. That's in order so the fracture's out to length and you can see where the fracture fragments are. Some people would argue that there's an advantage to doing it after, but the majority doing it before, but the majority do it after. The key aspect when you're dealing with pilon fractures and external fixation is do not make an incision unless you're the person who's going to be definitively taking care of the patient, because you may then limit someone's ability to make an incision what they want. What I mean by this is, let's say you make a directly lateral incision to fix the fibula, and then I wanted to go posterior laterally to fix the posterior malleolus. Now you've obviated my ability to do that, because you can't put incisions too close. And the rule of thumb is not about absolutes. The distance that you can be next to another incision around the ankle is the length of the incision. What I mean is, if you're only making 1 centimeter incision, you can put it 1 centimeter apart. It's as you get bigger. If you're going to make a 6 centimeter incision, then ideally you're 6 centimeters away from your other incision, 6 centimeter incision. And so it's less about absolutes. And so the whole distance has been called into question. But this is the view that we look at. And so as you can see, She's got a fragment laterally, but she also has this stellate fracture coming through the plafon, and we know that we need to fix the posterior malleolar piece. And so there's a couple ways you can do this, right? I need to access the window. One of the ways is to go laterally and then posterior medially in order to be able to then see here, book it open, and get everything aligned. Another option is you could go posterior laterally, fix the fibula and the posterior malleolus, but then you have to flip the patient potentially and go anterior medially. And so there's not always one right way, but it goes back to that first slide about windows. These are the windows: anterior medially, posterior medially. And so as you can see here, because there was such a vertical shear and anterior component, we did go posterior laterally and then flip her and go anterior medially. I think you could be readily justified, and maybe now, this was a number of years ago, I probably would have gone posterior medial and lateral and avoid the flip. But everything goes back to these windows. How do I access this opening? Because if I let's say go anterior laterally, I'm going to hit this area here, and I can't see into the joint. It's these fracture fragments that let us see into the joint. And because you're prepared ahead of time, you also know, do not strip the capsule from fragments. And so I'm going to open up the capsule here, but I will not denude this anterior lateral piece of capsule because that's its blood supply. So don't forget that bone is a living thing. This is a 54-year-old scientist, was in a sledding accident. It's interesting. I moved this forward. It used to be case number 9 because I wanted to make sure we have time for it. But if you notice, her joint is reduced, meaning her ankle's not dislocated, but look at the angle here. What she has is impaction of the anterior plafon. And so while the joint maybe looks like the mortise is reduced, this is actually an injury that needs to be fixed because the whole angle of the joint is off. The front needs to be pushed downwards to create better coverage. She has very little anterior coverage of the talus, and if you were to not fix this, she would have long-term consequences at the front rather than at the back of the plafon. And so I don't know if the movies are going to play, but this is what she had. You can see that there's a huge impaction up the front, and the entire distal metaphysis is angled upwards. And so realize that it's not only the posterior portion of the ankle that can be rendered unstable, but also the front. Look how much uncoverage she has in her talus. And so in those kind of situations, what you actually have to think about is pushing the front down and then using bone graft, some sort of graft to fill in that void. And so often in ankle fractures, the distal tibia is metaphyseal. And so have a low threshold if you're going to be pushing down and leaving a void of backfilling. But don't forget these impaction injuries. They can happen in a lot of locations, especially anterior laterally. And then, and so we used an anterior lateral approach to access this, as well as a medial approach. This brings up the role of compromise. This is a 90-year-old female who slipped getting out of a chair. She lives independently, and she presented to the ER with this X-ray and this CT scan. Now, this is the part where I often pause and ask, what do you want to do? Realize she's got a huge die punch fragment right in the middle of her plafon. But the reality for her is her joint is still located. She's over 90 years old. And our goal is ultimately just to keep the bottom half of the ankle under the top half. She was initially treated by a colleague, not without surgery, and then she came to her clinic this way. And then she was referred to us. And so this is about the role of compromise. Now what? And so her skin quality was not good. And so this is the role of percutaneous fixation. We actually used little poke holes to try and hold everything in place and just stabilize the ankle. I was prepared to put on an external fixator if need be. And this is how she was healing. And she actually ultimately did well and continued to live independently. So realize the goal of compromise. She had skin that was not very amenable to an incision. Our goals for her was to remain independent and ambulatory, and we were able to achieve them with compromise. This is a 53-year-old male diabetic, slipped on black ice while riding his bike. And so again, first things first is put the joint into place and get a CT scan. As you can see, he has a vertical shear here. He's got a posterior malleolar fracture as well as a fibular fracture. As you start doing more of these complex ankle fractures, the important part is study the axial. And this is what I'll give you. I would like you to have a moment to think, how would I approach this ankle fracture? Where is the window? And so as in case, the big window is posterior medial, right? This is the part that's going to let you access this piece, and realign the joint. And so in his case, we did a posterior medial approach, and we're able to fix them that way. We used screws just to minimize hardware, but a plate would have been perfectly fine as well. And so this is where I want you to think about. Start thinking in terms of windows. How do I access? And it all goes back to that original MRI slice that talked about anatomic planes. This is a 38-year-old female. She was a pedestrian struck with her foot and ankle crushed and pinned by a van. As you can see, she's got plafond irregularities, as well as a big posterior piece. I'm going to jump to the CT scan, and you realize, again, what are our windows? How are we going to fix this? And realize this star right here correlates with this piece. And so remember what I told you originally, that unfortunately, when you access the ankle posterior laterally, you cannot see into the joint. I urge you to look at a sawbone. You have a big overhang of that posterior malleolus. And so if you're going to need to approach an ankle posteriorly, and you're going to have to do something to articular fragments, often that means approaching it posterior medially. People are often nervous about it because of the neurovascular bundle, but it's readily dissected and moved aside. And if you're comfortable with the anatomy, it's readily done. And so she had a posterior medial approach in addition to the lateral plating. And as you can see, the plafond is now well created. The one part I want to make sure to comment is, how well can you see this piece right now? The articular piece that we highlighted with that star on this x-ray, because you're going to look at it on a lateral. Not very well, right? And so as the majority of the time when we're fixing ankle fractures, we'll fix the fibula first. Realize that if you're going to do a lot of plafond work, it may be worth at least considering approaching the tibia first. Not necessarily because it's wrong to fix the fibula first mechanistically, but a plate over the fibula, especially if you're using a 1/3 tubular, will block your ability to see the plafond. And so we're getting to the end. I know we're running out of time. This is a 61-year-old male who was hiking in Italy, returned 4 days later, and presented to the ED with these films, still dislocated. And so he had self-dislocated at home. They had put him into place in Italy, and he self-dislocated. And then this was circles and arrows that we didn't put on. And so he was pulled back into our place by one of our residents. And again, you see this posterior comminution. And so then you start asking, what are my windows? And so in this case, you can go laterally, posterior laterally and medially, or you could go posterior medially and laterally, right? You need enough space. The reason I bring this up is, one, if you go posterior lateral and you put this piece into place, realize that while we often talk about fractures being a jigsaw puzzle, they're a three-dimensional puzzle. If you were to fix the posterior malleolus first, without this posterior medial fragment, notice how this place locks and interdigitates in. It will prevent you from being able to put this piece back into place. So often I urge you to make both approaches at the same time to allow you to maneuver both pieces, and don't make the mistake of fixing one definitively with a plate and screws and realizing that you can't fix the other. And so in his case, we may add a posterior medial approach, and then as well as a direct lateral approach. And the reason was in order to be able to work on both these pieces at the same time. It wouldn't have been wrong to go posterior lateral, but then you would have had to go directly medial and somehow put this piece in before putting in this piece. Otherwise, you would have blocked yourself. It's a three-dimensional jigsaw puzzle. The other advantage of fixing medially first, as I mentioned before, is notice this plate. It makes it hard for me to see this area. Whereas because we fixed the tibia first, I could know that the plafond is well aligned before I start putting hardware elsewhere that prevents me from being able to see. And this doesn't necessarily mean not putting the fibula into place. As you notice, there's already a lag screw through the fibula, but we put that first because that can help with your reduction. But set yourself up for success fluoroscopically. And this is our last case. This is a 65-year-old physician who fell in a ditch. You can see that there's a posterior malleolar fracture. If you have access to it, I'd strongly recommend a CT scan. And what you see here is that while this AP looked really reassuring, and even here, she doesn't look overtly dislocated, when you get the CT scan, you realize that her ankle is subluxed. And when you see this fragment, you see that it's a more traditional posterior malleolar fracture. So she can be approached posterior laterally. Truth be told, that's not what we did. We actually did a transfibular approach. And I wanted to bring this up as one, you can approach the posterior malleolus if it's a simple pattern through the fibular fracture. You actually open it up, clean out the posterior malleolus through the fibula, reduce it, and then put an A to P screw. And so you can do transfibular approaches to the posterior malleolus through a direct lateral approach. I just wanted to bring that up as another option. And so thank you for your time. Hopefully this is helpful. I realize it was a little bit whirlwind, and at some point I'd love to meet y'all in person and be able to have a more robust conversation back and forth. But it's an absolute pleasure and honor to be able to share this presentation with you.